Welcome, everyone, and thank you for attending today's program titled Reclassifying Risk of Malignancy in Indeterminate Pulmonary Nodules using the Nodify Lung Testing Strategy. My name is Kieran O'Kane. I am the Chief Commercial Officer at Biodesics. It's my pleasure to introduce our speaker today, Dr. Michael Pritchett. Dr. Pritchett is the Director of Thoracic Oncology at Firsthealth of the Carolinas and Pinehurst Medical Clinic. He is also the current president of the Society for Advanced Bronchoscopy and the principal investigator of the Oracle study, a clinical trial designed to evaluate the utility of the Nodify XL2 test in a real-world clinical setting. As such, Dr. Pritchett has extensive experience with Nodify testing and will discuss today the challenges of managing indeterminate pulmonary nodules, initial results from the Oracle trial, as well as case studies and national data demonstrating how the Nodify Lung testing strategy is being used by physicians across the US. There will be time at the end of the presentation for a Q&A. Please type any questions you have into the chat box, along with your name and location, and we'll answer as many as we can at the end of the session. So without further ado, I will hand over to Dr. Pritchett.
Thanks so much, Kieran. I appreciate the introduction. My name is Dr. Michael Pritchett, and I'm here to talk to you today about the use of Nodify lung testing to help reclassify malignancy in indeterminate pulmonary nodules using this test. So let's talk first about the current state of nodule management, because it has a lot to do with why we have this test in the first place. Let's take a look at a few examples first. What would be your next step for these patients? The CT scan on the left, you see this is a patient who's asymptomatic, has a 2.8 centimeter solid lesion in the upper lobe, maybe even a little spiculated. There's an airway going to it, which certainly may tempt you to want to do bronchoscopy on this, compared to the image on the right, which is a much smaller lesion, kind of in a half moon shape along the side of a vessel, almost out to the pleura, and is only 9 millimeters, certainly not necessarily something we would want to jump in and biopsy. What if we had a test that was going to help us make those decisions, and specifically a non-invasive test, which is just a blood test? So fast forward here 8 weeks, the follow-up CAT scan on the left shows near complete resolution of that lesion, which was clearly just inflammatory or infectious. Conversely, you look at something on the right that took over 2 years after the initial detection to show that this actually progressed. This was ultimately resected and showed a stage 1A adenocarcinoma. So 95% of nodules are found incidentally, and so we use the information that we have in front of us, like their age and the size of the nodule and whether it's spiculated or not, and the location, their smoking history, and that goes into our risk calculator, right? So for incidental nodules, we prefer the Mayo calculator because it's a little bit better predictive model with that. With lung cancer screening nodules, we may want to use the Brock model or calculator as a preferred method. So we use those numbers to come up with a risk category. 26% of those patients get immediately pushed into a high risk category, okay? So what you'll see there is the vast majority of these, we don't know what to do next. They all fall into this 5 to 65%. And the question is, do we biopsy? Do we do surgery? Do we do a PET scan? Do we just watch this? And what's the impact on the patient as well? If you do a CT scan follow-up in 3 months, what kind of confidence does your patient have that they have a benign lesion that it's nothing to worry about? Or are they going to go to bed every night thinking that they may have lung cancer? And why is my doctor waiting 3 months? So we'd like to figure out a way to hit the easy button and push a lot of these down into the very low risk category there. And I'll show you exactly how to do that. So here's the current state of lung nodule management. We have low to moderate risk nodules. And again, they're often managed by aggressive methods, which in some cases is good. If we look at the data from the Panoptic trial that was published in Chest not long ago, what we found is that these numbers match up almost identically to other studies that have been published as far as what happens to these nodules. So 17% of patients got sent to CT surveillance, and they eventually ended up having cancer. 38% of biopsies are actually performed on nodules that are benign. So it's not horrible. We're being aggressive, but we did a relatively minimally invasive procedure like a bronchoscopy or maybe a CT-guided needle biopsy, even though that can be invasive. The worst thing probably is that 20% of these patients go to surgery and have a lobectomy or a wedge resection for something that is ultimately benign. So how can we improve this strategy of nodule management? And that's by classifying these patients better. So when you think about all those options, you really need to weigh your treatment decisions. And part of that is looking at the adverse events of the procedures that you're considering doing. If you look, your patient safety indicator, or basically a marker of any possible complication that you can have, you can see there's 25% for bronchoscopy, even though that's generally a safe procedure. Yes, it has much less iatrogenic pneumothorax, but these patients can have respiratory failure from anesthesia and things like that. Percutaneous biopsy, surgical biopsy, now you're above 30% risk of complications. The other thing to weigh into that decision is, what is your diagnostic yield for bronchoscopy? We know that traditionally the diagnostic yield for bronchoscopy isn't that great. Even when your pretest risk of cancer is greater than 60%, you only have a 77% diagnostic yield. And then it really depends on the size of the lesion. When we're talking about lesions between 1 and 3 centimeters, we're still only about 60% chance of getting the patient a diagnosis that day. For lesions greater than 3 centimeters, only 78%. And these numbers may be very variable based on your institution. So you have to factor that into your decision as well. So let's talk a little bit about Nodify Lung, blood-based lung nodule testing. And this is a combination of proteomic tests. You have something called Nodify CDT, which is a blood-based autoantibody. It tests for 7 autoantibodies. This is our rule-in test. And you can tell that by looking at the specificity and the positive predictive value. Those are the 2 numbers that you want to be really high in a positive rule-in test. Conversely, on a rule-out test, like Nodify XL2 that you'll see on the right, we want a highly sensitive test with a high negative predictive value for a rule-out test. Both of these have extensive publications. Nodify XL2 has fantastic Medicare coverage. I've used this test specifically in a trial called the Oracle trial, which we're excited to present a poster here at this meeting, specifically at ATS, about our early results with this test. I personally have done over 150 of these tests. We've never had any tests come back uncovered or a patient getting a bill, and that would be a non-starter for me. If my patients are getting bills that aren't covered by their insurance, then I'm just not going to do that test, and I can say that we have not had any of those, and that's very exciting. The situation is going to end up being the same with CDT, and I'll tell you how these tests are used together and what the reflex method is and the methodology behind that. So the Nodify CDT test can help identify candidates for intervention. These 7 autoantibodies that are listed here on the left side of the screen are what is being measured. This is a very specific test, and again, that's what you want for a rule-in test like Nodify CDT. So when we set the specificity at 93%, what we see is that the sensitivity of this test is pretty good across all stages and all types of cancer. Obviously, we can't look at a nodule and know specifically what type of cancer that is. It could be small cell, non-small cell, it could be stage 1, stage 4. It's nice to know that this test has generalizable sensitivity across the board between early and late stage and between various types of cancer. The Nodify XL2 is the other part of this study. And what this is specifically it's a ratio of 2 proteins. There's one protein called LG3BP that's been shown to be significantly elevated in patients that have lung cancer. There's another protein called C163A, and that's been elevated in inflammation. So what we use is a ratio between those 2. And when the ratio leans more toward lung cancer, it changes your risk. When the ratio leans more towards inflammation, it decreases your risk. So we use the results of that ratio in combination with the clinical factors that we know have already been validated: the location, speculation, smoking history, age, and we combine all those things together, okay? So what you see here in these bluish gray colors in the middle are, this is your pretest probability. You did your Mayo risk calculator, that's what your numbers are. What we're showing you is how widely you can change the risk classification for your patients with a simple blood test. If your patient has an elevated expression of those autoantibodies, it may push you up into the red. What we see a majority of the time, fortunately, is that the Nodify XL2 result pushes you down significantly from your pretest probability. And a lot of times it pushes you down less than 5%, which is, again, the easy button where you just already know what to do, CT surveillance. You also give your patients the confidence that this is likely benign. So this is a graph, a scatter plot of basically my patients that I've tested at my institution. And what you'll see on the left is the pretest risk of malignancy. So a lot of those are less than 25%, but most of them overall, fall between 5 and 40%. Look at the change in the post-Nodify XL2. We just shifted a ton of patients into the very low risk category, specifically less than 5%. So the one thing that we want to do whenever we do a clinical trial or a study is we say, yeah, that's your patients at your site and your institution. How do I know that these results are generalizable? I live in the histo belt. I live in the cocci belt. You live in the lung cancer belt. And that's true. So how generalizable are these results? This graph will show you. This is the results of national data, all combined, from Oracle study patients to commercial use of this. And what you'll see again in the graph on the left, you have a very small proportion of patients who fall in that very low risk category of less than 5%. Shift that over to the right after the test, you have a significant increase in the overall population of patients that have now safely avoided an invasive procedure and have just gone on to CT surveillance. And again, probably associated with decreased anxiety levels in your patients about whether or not they may have cancer. All right, so we did the Nodify XL2 testing in 4 patient cohorts. Specifically, we looked at never smoker, prior cancer, whether it was spiculated, whether it was in the upper lobe. And this is a comparison across multiple studies. So you had the original Panoptic trial. Then if we make the criteria a little bit more strict, meaning that we keep it at 50% pretest probability or less, that's pan strict. So what we're trying to show you with these graphs is that overall the patient population is almost identical in all these studies. We do have a slightly older age population in Oracle, and we have slightly less incidence of spiculated lesions in Oracle. So look at the distribution of the risk of malignancy when we use the Nodify XL2 test. If you look at the image on the left, this is data from the Panoptic trial. And on this violin plot, what you see on the left is your stratification on pretest probability based on Mayo Risk Calculator, and then your post-test. After applying the Nodify XL2 data, what we see is a vast majority of those patients fall under that 5%. Again, is this generalizable? So that's the strict cohort, the sub-cohort, if you will, of the Panoptic trial. Then we go to commercial. So is this generalizable? There's your answer. This is people using this every single day out in the community and at academic centers, showing you that it's generalizable when used in a commercial population. We have 41% of patients that get reclassified to less than 5% risk of malignancy. How about from the Oracle trial? Again, we have an ATS poster presentation on this if you want to learn more about it. This shows you 46% of patients get reclassified. That's almost half of the patients that you're dealing with an incidental nodule on between 8 and 30 millimeters that we've now pushed down to less than 5% risk of malignancy. And that's fantastic. So let's talk about a couple case studies here. One at the end. This is a 71-year-old male. He was a current smoker, 50 pack year history of smoking. And he's got this solitary incidental pulmonary nodule, but no history of cancer. So he has this 10 millimeter pleural-based nodule, smooth, rounded, looks concerning. So we did Nodify XL2 on him within the Oracle trial. His pretest risk of malignancy was 12%. Not bad. It's in the lower lobe. It's 11 millimeters. It's not spiculated. But we do the blood test, and it shows actually there's less than 1% risk of this patient having a malignancy. Based on that, we said, all right, we're going to do a short-term follow-up CT scan, which we did, and the nodule completely resolved on follow-up CT scan at 3 months. This is a great way to help manage your patients, avoid invasive procedures, and give your patients some comfort and less anxiety going home for those 3 months. So how does this risk reclassification work overall with the lung reflex test? So you take your patients that are between 5 and 65%, that kind of low to moderate risk patient that we don't want to do invasive procedures on unless we have to. We do a blood draw in the office. The first test that gets performed is Nodify CDT. The results of this test come back in 1 day. If these patients have a positive result on this, that immediately shifts them into the very high risk category, greater than 65%. And that's kind of a no-brainer. That pushes you to do some type of invasive biopsy, whether it's bronchoscopy or CT-guided needle biopsy or directly to surgery. The majority of your patients, if you remember that graph from the beginning, 72% of patients will end up still in this low to moderate risk category, and then they get pushed to Nodify XL2. And then based on those results, they may get pushed down in risk just to CT surveillance. They may come right in the middle, and then you kind of have lots of different options from biopsy to PET scan to CT surveillance. And then there's also an indeterminate result there as well, and we'll talk about what that means. So let's look at another case study. This is from Dr. Skibo outside of Asheville, North Carolina. This is a 64-year-old patient that had a spiculated 10-millimeter nodule in the right upper lobe. This patient was a current smoker, had no prior history of cancer. The patient was not comfortable moving forward with a diagnostic procedure. I can't tell you how often we see this, particularly for very small lesions like this. The patient may not want to have an invasive procedure. So how can we use a blood test to try to help us one way or the other in terms of convincing a patient whether they should or should not have a procedure? If you look at the pretest probability, 39% risk of malignancy just because this is an upper lobe spiculated lesion in a patient that has history of smoking. The PET scan had a little bit of increased uptake at 3.3 on the SUV, but nothing out of this world. The Nodify Lung test was ordered, and the result based on the Nodify CDT was immediately high risk, specifically 90% risk of malignancy. And that was used to help this patient decide to have a navigational bronchoscopy by Dr. Skibo. During that same bronchoscopy, not only did they make a diagnosis on that lesion, they were also able to stage the patient with endobronchial ultrasound to come up with a final diagnostic stage of 1A in a patient that had adenosquamous carcinoma. So here, the Nodify CDT test was used to appropriately risk stratify that patient to a much higher risk of malignancy from the initial 39% up to 90% and help make a decision for that patient to have an invasive biopsy. So how do those early CDT results look when you order them? So again, it's all based on the magnitude of the result in terms of what's the expression level of those autoantibodies. In a high level, that patient is immediately pushed up into the high risk category, greater than 65%, no further testing is done on the specimen. They may have just a moderate level of increase of the autoantibodies or expression of those autoantibodies, and then you still get some results. You still get a shift there. We went from 30% risk of malignancy up to 49%, but it didn't necessarily push us way up. But again, it did increase that overall risk of malignancy. And then you may have patients where you have no significant level of antibody detected at all. And what that's going to do is automatically reflex to your rule out test. These are the results of your rule in test. And if you don't have a result there, you move to the rule out test. So let's talk about another case study. This is a 73-year-old patient from Dr. Hogarth's office at the University of Chicago. This patient presented for bronchoscopic lung volume reduction. That means the patient has severe emphysema with air trapping, probably not a great candidate for invasive biopsies in the first place. So this patient has a spiculated 10-millimeter lesion in a really difficult place to biopsy in a patient who's a current smoker. They have no history of lung cancer. The pretest probability for this was almost 50%. You might as well flip a coin as to whether your patient has malignancy or not. That's fairly high. There was some activity on PET scans, specifically an SUV of 7. So Nodify testing was ordered, and this patient shifted almost into the very low risk category. They went down to 6%. So that's a huge drop from 49% down to 6%. And so that affected their clinical decision-making. Dr. Hogarth was able to have shared decision-making visit with his patient and recommend a short-term follow-up CAT scan. That lesion reduced dramatically down to 7 millimeters. Cancer obviously doesn't do that. So this was clearly an inflammatory or benign etiology that was indicated, and the patient is able to go on and have their lung volume reduction procedure. So how do we interpret the Nodify XL2 results? They can come across in a multitude of fashions. And what we see here is that your pretest risk may be one thing. In this case, it happens to be 30%. And your result may come back as 98% negative predictive value. And that will indicate that this is likely benign. That pushes that patient down, in this case, to 3% risk of malignancy, into that very low risk category that we like to see them in so that we feel confident doing follow-up CT scans. What I've been asked multiple times is, what is the false negative rate with this test? It's about 3%. So 3% of the time where your test result comes back as likely benign, that patient will still have cancer. We're not trying to say, hey, if this test comes back likely benign, don't ever do another CT scan on this patient. You still have to weigh those clinical risk factors. Think about it compared to a PET scan, which can have a false negative rate between 10 to even as high as 20% false negative rate. We've all seen lesions that have no uptake on PET scan, yet they end up being malignant. So again, only 3% false negative rate with this test compares very favorably to that of a PET scan. You may get a result like 95% negative predictive value. This will indicate that there's reduced risk. We won't go quite as far as to say it's likely benign, but we'll say that it's reduced risk. And in this case, you can see the decrease from 30% risk of malignancy down to 10% risk of malignancy. The sensitivity does fall off a little bit as we go down this ladder. And so what we can see here is that we still have reduced risk, but not quite to the same magnitude as when we had a 95% negative predictive value. And then anything that comes back less than 90% will be an indeterminate result. And that's just a higher ratio of that protein that's more associated with lung cancer that pushes you down towards that indeterminate result. And then what we're saying is you should use your standard of care, use your gestalt, use whatever method you want to make a decision as far as what you want to do for that patient. What I'll tell you in my own personal experience is when I get an indeterminate result, that increases my suspicion for lung cancer. And we've found a lot of patients that wind up having an indeterminate result that go on to have lung cancer. So in terms of acting on that indeterminate result, a lot of times I'll be a little bit more aggressive than I normally would be. So that's the end of the presentation. Hopefully we've been able to tell you that this test can be used across all pretest probabilities. Even if you have a patient with a very low pretest probability or intermediate, or even something in the more 40, 50% range, there's still a value for this reflex test, whether it's ruling in or ruling out. With that, I'm happy to take your questions, and thanks for listening.
Pritchett. Very, very informative. We are going to open up the session to questions. We don't have a live Q&A feature for you to submit questions verbally. Please open up the chat box here and submit your questions through chat, and I will do my best to moderate and get through any that we have. We don't have any questions just yet, so why don't I open it up? And George, your case studies, that's obviously a great insight into some of the utility of the test. But you mentioned the amount of tests you've run in practice. Can you talk about just generally how useful have you found it? How often does it really change your treatment plan for the patient?
Yeah, it's a good question, and I have to admit, I'm probably the perfect person to talk about this because I was super skeptical at first about a blood test that's going to somehow outsmart me. And my years of practice and doing this, and I feel like I have a good kind of gestalt on things. So I was pretty skeptical at first, and you guys heard some of that when we first started doing these cases. But what I've really realized is that it does help me manage this. And so you saw on those violin plots when my patient's risk is so much different than what I thought it was based on a calculator. So calculators are great, but again, they can only help you so much. So this isn't meant to replace a calculator. This is meant to use in addition to your gut feelings, in addition to your gestalt, in addition to the calculator, in addition to you looking at the PET scan. It's not meant to replace anything. It's really just a nice adjunct. What I can tell you is that it helps more than anything, and some people may find more use in this than others, but I really like sharing that information with the patients, and I can tell you that the patients love it. When we're doing this trial and I talk with patients, I say, okay, here are typically the options that we have: PET scan, biopsy, 3-month follow-up, CT scan. And then I say, or I could do a blood test, and their ears just immediately perk up. This is, I think, the type of medicine that they've always envisioned that we actually do, right? Like, medicine is so advanced now, we can just do a blood test and we can tell you everything. That's what they've envisioned that it is. But we know that it hasn't really been that way. But now it kind of is. And so when they hear that there's a blood test they can have, they really perk up. They'd rather do that than wait 3 months without any answers. Some of these patients go home and they go to bed every night and they wonder, do I have lung cancer? Well, I'll have to worry about it tomorrow because it'll still be there because my doctor's going to do a CAT scan in 3 months. So the patients have really found a lot of information from this, and it helps really in these shared decision-making conversations. And certainly we express the limitations of this. We express the limitations of a PET scan. Remember, PET scans have a false negative rate of 10, 15, sometimes 20%, especially depending on the lesion. Is it a ground glass lesion? Is it a carcinoid tumor? A PET scan may not pick up on those, so it has a higher false negative rate. This test has an incredibly low false negative rate, of about 3%, and that doesn't discriminate between ground glass lesions or solid lesions or spiculated lesions. So it's been very helpful, and it's changed my practice, although not a ton right at the beginning. I really needed to get some experience under my belt, and not only that, but to really learn from the test. I have to wait. So I get the test, I decide to wait. I need to wait 3 months and 6 months and 12 months when they do their follow-up CT scans to see how much trust I have in this blood test. And as time has marched on and I've seen more of these follow-ups, or I've done biopsies when I didn't trust the test and I did a biopsy anyway, or something like that, all that has collectively added to my education on this product and has made me much more comfortable with the accuracy of the results.
Excellent, thank you. We do have one question in from the audience. Really looking at what's the patient prep, is that fasting, what runs up to that drawer?
Yeah, so it doesn't matter. They don't have to be fasting or anything like that. The Nodify has kind of changed over to just a little single pinprick on a card, and they put it on there. So it does not have to be a fasting test, which again is great, right? Because you don't want to say, hey, I want to do this blood test on you, but you're going to have to come back tomorrow. Some of my patients drive an hour and a half from a different state to come see us. I don't want to have to say, well, you ate breakfast this morning, or you had, something else, or you just took your other medicine, so you can't do this. So the short answer is it's not affected by anything. You can draw the blood test anytime, day, night, food, not food, or anything like that.
And I know not every pulmonology office has access to phlebotomy services. You do, correct? You draw in office. It might be worth adding as well that as a company, we're aware of that issue. We're aware that not everyone can draw in office, so we provide additional solutions as well, including mobile phlebotomy services, so we can go with a phlebotomist into the patient's home or place of work, draw there. And we have a number of relationships with kind of the storefront type labs as well, where the patient can go in and have the blood drawn there for the test.
Yeah, and that's a great point. And actually at the very beginning of doing the clinical trial, we weren't able to use our local lab. We had to use this kind of concierge phlebotomy service. And it was a really nice thing for our patients. And then now you fast forward a year, and we never could have imagined that we're going through what we're going through with coronavirus and things like that. Some patients are afraid to leave their home, things like that. So having another option for patients to have a blood draw because you're right, not every office has their own phlebotomy lab or anything like that. So we're lucky to have that, but there's plenty that don't. So having multiple sites that they can drive to and have their blood drawn for this test is good. And also basically a concierge phlebotomy service that will go to their house. They're wearing a mask and everything else, and they'll do their blood draw for them, and they don't have to go anywhere. A lot of these patients obviously are at high risk and don't want to leave the comfort of their own home, and we can still accommodate them.
Excellent. That was the last question from the audience. One more from me. It's really a commonly asked question on the type of patient that can be tested. What do you do with patients who present with multiple nodules, which is not uncommon?
Yeah, it's not uncommon, and so we didn't really know how to handle that at first. And we sent questions. When we were on maybe our third Oracle study patient, are we allowed to do this in multiple nodules? The answer is yes. And so this test doesn't discriminate between that. Now, if you have two concerning nodules, the test is not going to tell you which one may be concerning, which one isn't. But what it can tell you is that if it pushes you down to the less than 5% risk of malignancy, that covers both of those nodules, or all three, or whatever the case may be. It just drops that risk factor for everything. So you still have to use your own intuition that if it's high. Now, what I will say is there almost always was one particular nodule that seemed to be more concerning than others. And it doesn't always happen. Maybe one was slightly bigger, and that's the one I kind of, in my mind, was doing the test on. The test is doing it on the patient's proteomic environment. It doesn't care how many nodules you have. So again, this is a rule. Initially, it's a rule out test. And so if it rules it out, it rules them all out. If it rules them in with Nodify CDT and it pushes you up on that autoantibody test to a high risk of malignancy, it does not differentiate which one. So you still have to biopsy. Maybe you need to biopsy both. Maybe they have synchronous primaries. Maybe they're metastatic lesions. So if you had to only biopsy one, I'd say you need to go after the one that looks most suspicious. We don't have to act like we don't handle multiple nodules. We do it all the time. We do CAT scans. And what are the guidelines based on? You make the decisions based on the largest nodule present. That's how you determine your CT scan follow-up. So you'll still have to use some of that intuition.
Excellent. Thank you for that. There are no additional questions from the audience, so I will wrap this up. Thank you, everyone in the audience, for spending time with us this afternoon. And thank you, Dr. Pritchett, for your time as well. Very insightful. Any follow-up questions, please get in touch with the company. You can find contact details through biodesics.com. Thank you. Have a good evening.
Thanks. Take care.